Hello and welcome to what is the first video on this channel. As requested, I will be discussing an approach to solving questions related to ABG analysis. I need a new name for my channel, but for now I've named it Just Your Everyday Medico. And since this is the first video, I'll take the opportunity to introduce myself. I belong to the batch of 2019 MBBS and I completed my internship this year, and I've given my first attempts for INI and NEET PG. And as I mentioned on the post on my Reddit account, this is basically me exploring my passion for teaching. So all criticism and advice is welcome because I'm just looking to improve myself. The objective of this channel is to discuss high yield concepts and mnemonics for PG preparation. And yeah, so I posted about this on r/Indian Medical School, and most of the people who replied did request ABG analysis, which is why we have this video. And if you guys liked what you're seeing, please do request new topics. I'm more than happy to do make more videos. With that said, let's dive into the topic. So what you see here is an ABG slip. This is from one of the patients I took a sample for in my internship. Now, there's a lot of values on the slip, but to be honest, we don't really need all of these, especially for exams. So what you do need to focus on are these three values: pH, partial pressures of carbon dioxide and oxygen. Then in electrolytes, you do need sodium, you need chloride. Occasionally, lactate helps in clinical diagnosis. And of course, you need to look for the bicarb, which is here, and your anion gap, which is sometimes calculated by the machine, sometimes it's not, and you have to do the calculation yourself. And well, the saturation of oxygen is mentioned, but usually that's not relevant when it comes to solving questions. So why are ABGs taken? So usually when patients present to the emergency department with dyspnea or tachypnea, we usually order ABGs for them. And if you've ever been in an ICU setting, you'll know that patients on ventilators usually have daily ABGs taken. So the reasons for taking ABGs can be classified into three main ones. One is, of course, to look for acid-base disorders. And this is the primary purview of our topic today. Apart from that, you can assess the oxygenation of a patient, and you can assess the ventilation of a patient. Oxygenation is given by the PO2, whereas the ventilation is given by the PCO2. Of course, acid-base disorders are usually identified by looking at the pH. Now, how do you take an ABG? Some of you might have the experience of taking ABGs, but in case we need to revise that, usually a 1 ml syringe is used. The syringe should be heparinized. This means the walls of the syringe should be coated with the heparin solution. The syringe itself should not contain an excess of heparin because heparin is an acid and will alter your values. There should strictly be no air bubbles in your sample, because if you compare the partial pressures of air and blood which is oxygenated, the oxygenated blood has a PO2 of about 100 and PCO2 of about 40, whereas air has a PO2 of about 150 and a PCO2 of just 0.3. So you can look at the wide variation in the PO2, and where there is a difference, where there is a gradient, there will be diffusion of gases. So if you leave the sample long enough, there will be diffusion and your values will be altered. So you'll be getting a wrong reading for your patient. And as a rule, ABG should be processed as soon as they're taken. This is because there are cells in the blood which will metabolize the glucose and will also lead to lower pH. But this is usually seen after 15 to 20 minutes of standing. Also, if you have to transport an ABG sample, ideally should be transported with ice pack. When it comes to puncturing the artery, imagine this is the artery. Your angle of insertion should be at around 45 degrees. And the needle used is usually a brown needle or 26 gauge. So before we interpret an ABG report, we need to know what the normal values are. And as I mentioned, we'll be looking at 5 basic values. That's pH, PCO2, PO2. Then we'll be looking at bicarb and also anion gap. The normal value for pH is 7.35 to 7.45, and this is the pH at which most of the body's enzymes and proteins are in the most optimal state. Normal value of PCO2 in oxygenated blood varies between 35 to 45 millimeters of mercury, whereas the partial pressure of oxygen varies from 80 to 100 millimeters of mercury. For bicarb, you can take 24 with a range of 2 milliequivalents per liter. And for anion gap, you can take 10 with a range of 2 milliequivalents per liter. So this is 8 to 12 and this is 22 to 26. These values are important because they won't be mentioned in the exam, but you'll have to remember what is normal. Okay, that being said, let's just see the basic approach when you see an ABG question. So obviously the first value you'll be looking at is pH, and that tells you whether there's acidosis, which is less than 7.35, or alkalosis, which is more than 7.45. Next, you need to determine what the primary acid-base disorder is. So it's either going to be a variation in the respiratory or the metabolic function of the patient. And what I mean when I use these words respiratory or metabolic is respiratory strictly refers to PCO2 and not PO2, whereas metabolic refers to bicarb. And this is basically all you have to remember when you're answering the question, whether it's a metabolic disorder or a respiratory disorder. After you determine which is the primary disorder, you also need to determine whether it's a compensated or an uncompensated disorder. So when there's a respiratory problem, there's going to be compensation from the metabolic aspect. And when there's a metabolic problem, there's going to be compensation from the respiratory aspect, which we'll be seeing in a bit. And this is a slightly higher level topic, but there are certain questions where there's a mixed acid-base disorder. So there could be something like a metabolic acidosis with a metabolic alkalosis, which we'll be exploring at the end of the video. Now, before we solve these questions, we need to have a basic understanding of the buffer systems of the body. There are basically 3 systems in the body that regulate the acid-base balance. And the most important one here will be the bicarb buffer, which acts immediately. So to understand bicarb buffer, you need to have the understanding of the equations which take place in the buffer system. So H plus combines with bicarb in a reversible reaction to yield H2CO3, which is nothing but carbonic acid. Carbonic acid is further degraded to H2O and CO2. This is by the enzyme carbonic anhydrase. Now, when the pH is within physiological limits, this equation will be in equilibrium. So suppose there is acid which is added to the system. For example, let's just take H2SO4 for simplicity. That would lead to an increase in the H plus concentration. And H plus is obviously going to react with bicarb. I'm just rewriting the equation here. But since there is more of H plus, the reaction is taking place in the forward direction. This leads to depletion in the bicarb level. And also, if you'll notice, the end product is carbon dioxide and water. So the lungs have to get rid of this carbon dioxide, because if there is product accumulation, the reaction does not carry forward. So the role of the lungs here is to exhale the carbon dioxide. And if there's an increased level of carbon dioxide, there will be tachypnea. And this actually manifests in metabolic acidosis as Kussmaul breathing. Kussmaul breathing refers to the rapid and deep breaths taken. Now, what happens if a base is added? For simplicity, let's consider sodium hydroxide is added to the system. This would lead to an increase in hydroxide, which obviously binds with hydrogen or protons to yield water. As a result, there is depletion of protons. Now, of course, the body needs to generate protons. So I'll just write the reaction again. So since the body needs to generate protons which are reduced, the reaction has to take place in the backward direction. So now carbon dioxide and water are actually substrates, and the end products are bicarb and protons. So the bicarb is going to be increased, whereas the carbon dioxide is now being depleted. Now, since carbon dioxide is a substrate, it needs to be provided again by the lungs, this time by retention of carbon dioxide. So, in this way, the lungs aid the bicarb buffer system in maintaining acid base balance. So, coming back here, of course, we've discussed bicarb buffer, and we've also discussed how lungs can either through hypo or hyperventilation contribute to the CO2 balance of body. The third system in the body is the kidneys, but kidneys take a long time to act. They take several hours to days to fully function. And the way they do this is through selective proton excretion or bicarb reabsorption. And this is usually done at the level of DCT and collecting ducts. In the kidneys, H plus is excreted in the form of ammonium ions. So ammonia, which is synthesized by the renal cells, combines with protons to yield ammonium ions. Likewise, bicarbonate can be generated by carbonic anhydrase, and it can be reabsorbed if there's a depletion or even excreted in excess. And here the lungs take hours to act. Bicarb immediate. So now you know that there can either be acidosis or alkalosis depending on pH. And you also know that the causes are either respiratory or metabolic. So as a result, you get four primary acid-base disorders, which are respiratory alkalosis, metabolic alkalosis, respiratory acidosis, and metabolic acidosis. And we'll be discussing each of these in detail now. So the first primary acid-base disorder we'll be discussing is metabolic acidosis. As the name suggests, acidosis is just pH less than 7.35, and metabolic refers to an alteration in bicarb. Now, what alteration in bicarb will we see here? Of course, in acidosis, there will be increased H+, which binds to bicarb. As a result, there will be depletion of bicarb, which manifests as low bicarb. This is what you need to remember. Now, coming to metabolic acidosis, it's further classified into two types based on something called an anion gap. So, met acidosis is classified into either high anion gap or normal anion gap metabolic acidosis. Now, what is anion gap referring to? Basically, anion gap is a representation of unmeasured ions, unmeasured anions to be specific. If you noticed in the ABG slip, we would only have values such as sodium, chloride, lactate, and bicarb. We wouldn't really see any other anions. And so we'll just derive the formula for anion gap. Now, in a solution, the positive charges and the negative charges are equal. So you can also represent that as cations are equal to anions. Now, the major cations in the blood, or which is an extracellular fluid, would be sodium and a little bit of potassium. When it comes to anions, it's chloride and bicarb. However, on the anion side, there are usually some unmeasured ions. So, unmeasured anions, which I will refer to as UA. Now, if we take these to the other side, you get sodium plus potassium minus chloride plus bicarb is equal to unmeasured anions, which is basically the anion gap. However, it's important to note that potassium is not routinely included in anion gap calculations. So, the actual formula that we use when we're solving questions is this formula, and this is what you need to remember for the exam. Now, you may be wondering what the role of anion gap is. Anion gap can help you determine the cause of metabolic acidosis. So basically, it differentiates the causes into whether there was excess acid that was added to the system or whether it was bicarb that was removed from the system. Since ultimately both of these result in reduced bicarb, so you can't tell them apart just based on bicarb. You need anion gap to help you differentiate these causes. So to further elaborate on this, let's consider a scenario where acid is added to the system. This acid in the body could come in the terms of lactate, which is lactic acid, could come in the form of oxalate, which is basically oxalic acid, which is derived from ethylene glycol. Now, ethylene glycol is used as antifreeze. It could come in the form of ketone bodies like acetoacetate or beta hydroxybutyrate. Now, you've noticed I've used the suffix ate for all of these: lactate, oxalate, acetoacetate, butyrate. These ates are basically all anions, and they're not measured by the ABG machine. So these are all unmeasured anions. So what would you expect if these are added to the system? Obviously, unmeasured anions are increased. So that would lead to a high anion gap. And that's just what we call a HAGMA, or a high anion gap metabolic acidosis. Let's consider a second scenario where there is basically depletion in bicarb. The most famous example for this would be renal tubular acidosis. So what happens here is, especially in type 2, there's a defect in the proximal convoluted tubule. And as you know, PCT is responsible for reabsorbing like around 90% of most solutes and even 99% of certain solutes. And bicarb is also included in these solutes. So if there's a defective reabsorption, all this bicarb is just lost to urine. So that manifests as low bicarb in the blood. We'll be discussing all the causes of metabolic acidosis now, but you have to remember RTA and also severe diarrhea commonly lead to this situation where there's only reduced bicarb, but there is no added acid to the system. So the unmeasured anions are normal, which is anion gap is normal. And this is called normal anion gap metabolic acidosis. Now coming to the causes of metabolic acidosis, and now we've just seen what HAGMA and NAGMA are. So the mnemonics used are mud piles or dumbbells or Kussmaul. I like Kussmaul because it also reminds you that Kussmaul breathing is seen in metabolic acidosis. I shall just expand these for you right now. Here M is methanol, U is uremia, D is diabetic ketoacidosis and includes other forms of ketoacidosis. P is paraldehyde. I includes iron or isoniazid. L is lactate. E is ethylene glycol. And S is salicylate, such as aspirin. Whereas Kussmaul K is keto acid. Which could be in the form of DKA or starvation ketoacidosis. U for uremia. S for salicylate. M for methanol. A for antifreeze. This U is already covered. And L for lactate. When it comes to NAGMA, one mnemonic that's used is called fused car, which I'll expand. F being fistula, specifically GI fistula. U being uretero-sigmoidostomy. So this is actually a diversion procedure where the ureter is draining into the sigmoid because the bladder has been removed due to cancer. S is small bowel fistula. E for extra chloride. So if there's exogenous intake of chloride. D is severe diarrhea. The term severe is actually important. C is for use of carbonic anhydrase inhibitors, which is like diamox, which is acetazolamide. A for Addison's disease, and R for renal tubular acidosis. So, I mean, severe diarrhea and RTA are important causes to remember. Now, after determining the primary disorder to be metabolic acidosis, we also have to determine whether it's been compensated or not. And that's where the concept of Winter's formula comes in. Now, if you'll recall, we were discussing the bicarb buffer. And when we increase the amount of hydrogen, we know that bicarb gets depleted, and the neutralization of H plus leads to the production of carbon dioxide, which is exhaled by the lungs. And this leads to tachypnea. So we expect a low PCO2 in the case of a metabolic acidosis. And this is termed as compensatory respiratory alkalosis. Alkalosis because it's counteracting acidosis. Now, to determine the adequacy of compensation, we use something called Winter's equation. Winter's equation gives us an expected value of PCO2 for the corresponding level of bicarb. So the formula goes expected PCO2 is equal to 1.5 times serum bicarbonate plus 8 and a range of 2. So let's use an example to demonstrate this equation. So now we know that normal bicarb is 24. Let's say in our patient with acidosis, they have a bicarb of 14. And so let's calculate the expected PCO2 for this patient. It would be 1.5 times 14 plus 8 plus minus 2. This is 21 plus 8 plus minus 2. So this comes to a range of 27 to 31. Now suppose in a scenario with bicarb of 14, the patient's PCO2 was actually 40. Now we know that we need a low PCO2, but if we're having a normal with a normal PCO2 of 40, that implies uncompensated metabolic acidosis. Suppose if the patient's PCO2 was 30, then it would fall within this range of 27 to 31. That's when you can call it fully compensated metabolic acidosis. So I hope this concept makes sense, because they usually do ask whether there is compensation or not in case scenarios. In such a case, the complete answer would be metabolic acidosis with compensatory or compensated respiratory alkalosis. It's important to remember that Winter's equation is strictly for metabolic acidosis. You cannot use it in case of metabolic alkalosis or respiratory disorders. Now the next disorder we'll be discussing is metabolic alkalosis. Metabolic suggests that there's a variation in bicarb, and alkalosis is of course a pH of more than 7.45. Now here we expect an increased bicarb, and of course if the pH is high, that means there's low protons. So what exactly is the variation here? Now if you recall the bicarb buffer equation, which I will write down quickly here. Here the problem is there is low H plus, and there's an imbalance, so there is a relatively high bicarb. Now to regenerate H plus, this equation has to progress in the backward direction. So carbon dioxide is a substrate, and as a result, the source for carbon dioxide is metabolic respiration, and the lungs have to conserve carbon dioxide in order to provide the substrate for this reaction. So there's actually hypoventilation in this patient, which provides a higher PCO2 so that the reaction can progress backwards and regenerate protons. This is termed as compensatory respiratory acidosis, because the primary disorder is an alkalosis, and to compensate for that, there has to be some degree of acidosis to bring pH back to normal. Now metabolic alkalosis is actually classified into two types, and this is called volume deplete or volume depleted, and volume replete. Replete means the volume is in balance, and depleted obviously suggests there's a low volume. And these are alternatively called chloride responsive and chloride resistant. Because, well, chloride here refers to IV normal saline. So if the patient's condition improves with IV normal saline, it's chloride responsive, and if it doesn't, it's chloride resistant. We can discuss the causes of metabolic alkalosis along with the mechanisms. So in the case of chloride responsive, one of the causes is severe vomiting. And this is just because there's loss of a gastric hydrochloric acid to the environment. So there's loss of H+, which leads to alkalosis, and loss of Cl chloride, which makes it chloride responsive, so response to IV. Another cause is use of certain diuretics, specifically loops and thiazides. Now, if you recall the mechanism of action of these diuretics, loop acts on the sodium potassium 2 chloride transporter. So of course this is lost in urine, so there will be low chloride. And likewise thiazide acts on the sodium chloride transporter in DCT. So consequently there will be a loss of chloride. And another cause is cystic fibrosis, which of course is a mutation in the cystic fibrosis transmembrane receptor protein, which leads to loss of chloride to environment because chloride can't be reabsorbed. That's the defect. When it comes to chloride resistant cases, one cause could just be exogenous bicarb. Another cause could be increased activity of aldosterone. This could be a primary disease like Conn's, or it could be secondary, or it could even be Cushing's because the steroids have some mineralocorticoid activity. And lastly, there will be hypokalemia can also be a cause of chloride resistant metabolic alkalosis. As for the mechanism in number 2 and number 3, if you recall in the DCT, when there is potassium in the tubule, this is the lumen and the cells are here. So there's actually this H plus K plus ATPase which reabsorbs potassium and exchanges it out for hydrogen. So as a result, if there is hypokalemia, the activity of this transporter is increased. So there will be reabsorption of potassium and loss of H+, which leads to alkalosis. And in the case of increased aldosterone activity, this aldosterone directly stimulates this transporter. So it's the same mechanism. And another cause is milk alkali syndrome. Now let's discuss the variations in metabolic disorders. And by this, I mean what are the respiratory variations in metabolic disorders. And so consider the case of metabolic acidosis. There is of course low pH because it's acidosis. We discussed that in metabolic acidosis, the bicarb is low. And there will be compensatory respiratory alkalosis and tachypnea, which leads to a low PCO2. So everything is low here. In metabolic alkalosis, there's a high pH, a high bicarb, and a high PCO2. Now, in the context of metabolic acidosis, we did discuss Winter's equation as a way to estimate compensation, but that can't be applied to metabolic alkalosis. And so, as a rule, which I will describe here, consider normal values. For bicarb, we know that the normal is 24, and we know that for PCO2, the normal is 40. Now, as you keep decreasing bicarb, this is of course acidosis. When you decrease bicarb subsequently, there will be a decrease in the PCO2 as well. And so for one decrease here, the decrease here is 0.75. So here that would be 39.25 and 38.5 and so on and so forth. In the case of alkalosis, per one increase in bicarb, the increase here is 1.25. So here it would be 41.25, 42.5 and so on and so forth. So this rule helps you estimate compensation in the case of metabolic alkalosis. Now we come to the topic of respiratory acidosis and alkalosis, which is more straightforward compared to the metabolic disorders. Here, respiratory refers to a PCO2 variation, and acidosis and alkalosis are pH definitions. In respiratory acidosis, we actually see an increased PCO2, which leads to increased carbonic acid production and increased H+, and the converse in alkalosis. So, rise in PCO2 is essentially because of hypoventilation, because the lungs aren't eliminating it. This can further be classified as central and peripheral. Central causes are usually due to CNS depression. Consider opioid toxicity or benzos, alcohol, or an acute stroke. In peripheral causes, they can either be neuromuscular disorders, for instance, Guillain-Barré or myasthenia gravis, or it could be due to airway obstruction. This could be acute severe asthma or a cardiac arrest. And chronic airway obstruction in the case of COPD would lead to chronic respiratory acidosis. Coming to alkalosis, alkalosis, of course, there's a low PCO2, which implies there is some hyperventilation going on. So causes for this include panic attacks or hysteria. And an important cause is hypoxia. Now, hypoxia might be tricky and might lead you to think of respiratory acidosis, but that's not quite the case. Now, here in hypoxia, when there's a low PO2, the body has to increase its respiratory rate in order to meet the oxygen requirements. And due to this increased respiratory rate, there will be increased carbon dioxide washout. So this is actually quite frequently tested. Hypoxia leads to respiratory alkalosis. It could be due to fever and in some CNS irritation. These are some causes of hyperventilation. Let me remind you that in acidosis, when there is a high PCO2, to compensate, the bicarb has to increase because bicarb is a base, and so there will be respiratory acidosis with compensatory metabolic alkalosis. And the reverse is true in alkalosis. When there is respiratory alkalosis, there is compensatory metabolic acidosis. Now, we discussed variations in metabolic disorders, so we can expect the same in respiratory disorders as well. So let's go back to the same concept. We know that the normal PCO2 is around 40 and bicarb is 24. Now, if we decrease PCO2, this would be alkalosis, and if we increase PCO2, this would be acidosis. Here we actually deal in multiples of 10. So we go 30, 20, and 10, and we go 50, 60, and 70. So here, with the change of 10, suppose a decrease in 10, the bicarb would also decrease by a multiple of 2. So this would be 22 and 20, 18, and so on. Here with an increase of 10, the increase is actually in 1. So it would be 25, 26, and 27. This is slightly tricky, so this does require a little bit of revision and practice. But what I've just described here is actually in acute cases. These conditions can also be chronic. And in chronic cases, which is easier to remember, the difference is actually just 4. So here minus 4 and here it's plus 4 for every 10 change in PCO2. So this would be 20, 16, 12, and so on. And this would be 28, 32, 36, and so on. I hope this is clear. Having discussed the 4 primary acid-base disorders, we now come to the last topic, which is mixed acid-base disorders, which is a more higher level concept and usually tested in INISET, not much in NEET PG. So the crux of the topic is basically centered around this concept called the delta ratio, denoted by delta. And it's a ratio of 2 deltas, right? So the delta in question is delta anion gap by delta HCO3. Or if I were to expand this, this would be measured anion gap minus normal anion gap divided by normal bicarb minus measured bicarb. So you're just comparing the change in anion gap with the change in bicarb. So what does this ratio tell you? The normal ratio is between 0.8 to 2. So if it's within this normal ratio, you can assume it is a pure HAGMA. So what if delta ratio is not normal? You basically have two cases. In the first case, a low delta ratio, which is less than 0.8. So what does that mean? If delta ratio is low, if you compare the numerator and denominator, it means that the denominator is higher than the numerator or expected. What does that mean? If there's a high delta bicarb, that means there is a high drop in bicarb. Now, there's already some HAGMA going on, but there's another factor which has led to further drop in bicarb, and that is a NAGMA. And this can be explained by just looking at the names. Now, there is some high anion gap here, but there's also a normal anion gap here. In both cases, there is a drop in bicarb. So obviously the expected change in anion gap isn't as much as the change in bicarb. So to simplify, low delta ratio equals HAGMA plus NAGMA. Alright, the other scenario is, suppose there's a high DR that's more than 2. What does that mean? Again, from the equation, that means the anion gap is higher than expected, or in other words, the denominator is lower than expected. What does that mean? A lower denominator or lower delta means there isn't much change in the bicarb. Now there is some HAGMA component, but there's something that's also bringing back the bicarb, so the net bicarb change isn't that much, and that is nothing but a metabolic alkalosis. So you know that the HAGMA decreases the bicarb, but the metabolic alkalosis increases the bicarb. So there is some balancing out, some equalization, so to say. So the bicarb drop isn't as much as expected, so the DR is high. So to simplify, high DR equals HAGMA plus metabolic alkalosis. And that's the end of this topic. Okay, so let's just apply the concepts we've learned. I've included a few examples here and we'll solve them step by step. So the first case, we've been given ABG findings and pH, PeCO2 and HCO3 are given. And we have to determine the acid-base disorder. So let me rewrite these. pH of 7.1, which is acidosis. PeCO2 of 55, which is high, which is a respiratory acidosis. And bicarb of 29, which is high and suggests a metabolic alkalosis. Now to determine the primary disorder, you just need to look for which one matches. Now the pH and the PeCO2 match, which implies the primary disorder was a respiratory acidosis. And now to compensate, there's a metabolic alkalosis. In this case, we didn't have to determine whether it was adequately compensated or not because that's not in the options. So we can just straight up go for option A. So the next question, they've mentioned an asthmatic boy was rushed with confusion and gasping and ABG has been done. So we shall rewrite these values. Alright, so pH is of course acidosis. PeCO2 is elevated. This would be a respiratory acidosis. Bicarb is within normal, more or less. And PO2 is not relevant to our findings, but there is hypoxia. And we also know that asthma can be a cause of respiratory acidosis because of hypoventilation, because the patient can't get out the carbon dioxide from his lungs. But in this case, we also have to look for whether there is adequate compensation or not. Now, I don't really need to apply a formula because I know that the bicarb is normal. And with a PCO2 of 70, I would be expecting a significantly higher bicarb value. If you recall the variations that we discussed, for every 10 increase, we should be seeing a 1 increase in bicarb. So the corresponding value for 70 would be 27. In this case, it's 26, so it's only partially compensated respiratory acidosis. In this case, a patient with CKD has come with complaints of vomiting and diarrhea, which is suggestive of uremic gastritis. But let's see the question fully. His blood gas reports show a pH of 7.4, bicarb of 23, sodium 145, and chloride 100. So let's write these down. pH of 7.4 is actually within normal range, and a bicarb of 23, which is almost normal. A sodium of 145, which is borderline high, and a chloride of 100. Now, at the outset, this looks like we could just go for no acid-base abnormality. But just to rule out any disease, let's calculate anion gap. So here it would be 145 minus 100 plus 23. And that actually gives us an anion gap of 22. And now we know that the normal is some 10 to 14 or so, or rather 10 to 12. So the anion gap is elevated. And this tells us there is some component of HAGMA going on. But what would lead us to a normal bicarb? So the next step after determining the fact that there is a HAGMA is to look at the delta ratio, which is delta Ag by delta bicarb. Now the delta anion gap, we know the anion gap is 22 and the normal is around 10. And the normal bicarb is 24, so 24 minus 23 in this question. That yields a delta ratio of 12, which is high. Consider that the normal is 0.8 to 2. And we know that high delta ratio is HAGMA plus metabolic alkalosis. And that would actually explain why the pH is normal and the bicarb is within normal limits. So here the answer is not A, but in fact D. For the next question, a 40-year-old man presented with nausea, dizziness and hyperventilation. ABG and electrolytes revealed metabolic acidosis with a normal anion gap. So we're looking at a case of NAGMA. Which is the possible reason for this condition? So we just need to look for causes of NAGMA. We know that lactic acidosis comes under L in our mnemonic. Chronic renal failure leads to uremia, which is U. And RTA we know is a common cause of NAGMA. Methanol is M in our mnemonic. So the answer here is RTA. Rarely you may end up with a question like this and asking you to identify the various acid-base abnormalities according to this nomogram. That brings us to this. This is called the Siggaard-Andersen Nomogram. Name is probably not important. So this is basically a nomogram and the variables here are H plus or pH at the bottom. Then there's bicarb here and there's also PCO2, which are these curves that you see here. And so we see that normal is of course our normal range and we're not going to focus on that, but rather how do we identify the various abnormalities from this graph. So the first step of course is to determine whether it's an acidosis or alkalosis. So watch as the graph goes this way, it's going to be acidosis, and as it goes to the right with increasing pH it's going to be alkalosis. And then after you determine acidosis or alkalosis, you need to look at the bicarb. When there's a low bicarb, we know that that corresponds to a metabolic acidosis. And when there's a high bicarb, we know that that's a compensation for a respiratory acidosis. And the converse is true for metabolic alkalosis with a high bicarb, and respiratory alkalosis would have a compensatory metabolic acidosis. Another thing you can look at is of course PCO2, and when there's a low PCO2, you know that corresponds to an alkalosis, whereas a higher PCO2 at the higher end would correspond to a respiratory acidosis. But the problem arises when you look at these two terms, an acute and chronic. So how do you know which one's which? If you look at this graph, I'll use a different color. The chronic respiratory conditions fall within a narrow range just outside the pH because the body has had enough time to compensate for the change. So at the end of compensation, there's very little left for the body to compensate for, and it's following very close to normal range. Whereas look at acute respiratory acidosis and alkalosis, they're falling way beyond normal. That's because the body hasn't had time to respond and adequately buffer out. So that's the trick you have to look at in answering questions related to the nomogram. Coming back to the question, let's just revise what we've learned. We know that this is normal, and we know that if we go this way, it's acidosis, and this way is alkalosis. If there is a low bicarb with acidosis, this is a metabolic acidosis. A high bicarb with alkalosis is going to be metabolic alkalosis. When you compare with normal, the conditions lying just outside normal are going to be chronic respiratory conditions. And with a higher bicarb, or rather a higher PCO2, this is going to be a chronic respiratory acidosis, and this is going to be chronic respiratory alkalosis. These are acute and acute acidosis, alkalosis, respiratory. So I hope this concept is clear to you. To summarize what we've learned so far, these are the reasons we take an ABG: to determine acidosis or alkalosis, to look at oxygenation and ventilation of our patients. And you need to remember the normal values in order to solve ABG questions. pH is maintained by bicarb buffer mainly, and then you have the lungs and kidneys. So when you're approaching a question, you need to first determine the primary change, then look for whether there's adequate compensation, and you can use Winter's formula in the case of metabolic acidosis only. And this is the formula. Delta ratio is applicable in mixed acid-base disorders, which is a slightly higher level concept. These are important mnemonics. We looked at mud piles for metabolic acidosis, for HAGMA specifically, and we looked at fused car for NAGMA. And RTA and diarrhea are important causes of NAGMA. And we also looked at how there is respiratory compensation in metabolic disorders and vice versa. This is just a table summarizing what I've taught you. And that brings us to the end of this class. Thank you. And this is my first video. I welcome all criticism, and I'm looking for ways to improve. If you found this helpful, do leave a comment below and let me know. The video production isn't as great as I want it to be, and it will be something I will improve in the future. I primarily used Harrison's as my reference for this video. So yeah, that's about it. See ya.